Good afternoon. Welcome, everybody. It's a pleasure to have you in our Epidemiology Department seminar series, which today we're co-hosting together with the Michigan Institute for Computational Discovery and Engineering. And today we have the pleasure of having Dr. Laura Matrajt from the Fred Hutch or Fred Hutchinson Center with us today. Dr. Matrajt, she got a Bachelor of Science in Mathematics from Mexico National University, and then a PhD in Applied Mathematics from the University of Washington. And I think after graduating, she's been at the Hutch since then, and doing amazing work in infectious disease modeling in different areas. And of course, as many of researchers in this area, and recently doing COVID work. And I believe she had the first peer-reviewed paper published on COVID or modeling COVID. I don't know if that's the case or not. Laura can tell us. But without further ado, thank you, Dr. Matrajt, and looking forward to the seminar. And yeah, go ahead.
Thank you. So you guys, thank you. You can hear me and see my screen, is that right? Yeah, great. And you can see my gigantic mouse. So thank you very much for inviting me to this seminar. I am really happy to be able to share my work with you today. I don't think I was the first one to publish something about COVID in mathematical modeling, but I am pretty certain I am the first one to publish something about vaccine allocation in COVID. And that's what I'm gonna talk to you today. And so I'm gonna talk to you basically about two big projects, and they all revolve around there. Sorry, my slides. So around vaccine allocation. And so this first project was published in early 2021 in Science Advances. It's a collaboration with Julie Eaton at University of Washington, Tiffany Long, and Elizabeth Brown at Fred Hutch. And so let me tell you a little bit about the motivation of this work. I started thinking about this problem back in May 2020, when it was clear that there were going to be vaccine trials, and that if a vaccine was successful, it was going to be the best way to control the pandemic. And because of my previous work thinking about pandemics in the context of influenza, I knew that if there was a vaccine, there were going to be shortages. And so we needed to start thinking in a way of who was going to get the vaccine first. We needed a prioritization rationale for vaccine delivery. And so what we did is we used an H-structured mathematical model, and we paired that with optimization algorithms to determine optimal vaccine allocation under a wide variety of scenarios. So basically, we were trying to answer this question: who should get prioritized to get the COVID-19 vaccines first? And so to do that, let me tell you a little bit about how we thought about this. So back in May 2020, the vaccine trials have not even started, at least not the phase 3. So we didn't know if and when a vaccine would be available, let alone how efficacious it will be, or how many doses there were going to be immediately available. And we still had many uncertainties about the natural history of COVID and disease progression. And that is actually still the case, but a year almost and a half ago, it was even worse. And different countries have had very different transmission dynamics. And in the face of all these uncertainties, I wanted to make minimal assumptions. And I also wanted to make very conservative assumptions, so that if I said that something was optimal, I wanted that to be true for a wide variety of scenarios, for a wide variety of vaccines. And I wanted this project to be able to answer this question, in the US or in Kenya or in Mexico. I wanted to give a general answer as much as possible. And so we were very conservative in the way we did this work. And so these are our key assumptions. We started with a transmission model of SARS-CoV-2 with 16 age groups that are listed there. We used the Washington state population as our baseline, and we used US demographics. And we assumed that asymptomatic and symptomatic infections were equally infectious and conferred equal immunity. And that's one of the things that we didn't know, and we still don't know if both of those things are true. And back then, we didn't have any sort of prevalence study whatsoever. And so we had to make assumptions about what was the level of pre-existing immunity in the population. And so we decided to do 20% of the population previously infected. But we also ran 10, 30, and 40%. And we started with 1,000 current infections. And an R0 of 3 that was calculated to be the R0 for SARS-CoV-2. And in case you don't know what R0 is a measure of how transmissible the pathogen is. And so basically I put here a schematic of them all. So if you look here, you start being, everybody in the population is susceptible, as we were all. And then once you get infected, you become exposed, and this means that you are infected but not yet infectious. And if you're exposed, you can have two fates. You either become an asymptomatic infected individual, but you can still infect a lot of people, but you just don't know, you have no symptoms, and then you're just recovered, or you become pre-symptomatic. And if you are pre-symptomatic, then the three things can happen to you. You have a mild infection and then you recover, or you become hospitalized in a general bed and then you recover or die, or you go to the ICU and then recover or die. And then on top of that, we layered vaccination. So here I only put one age groups, but we have 16 of these. And then in terms of the vaccine, we can think that the vaccine has three ways to reduce, to affect transmission or disease. So the first one is what I'm calling the susceptible, and that's the vaccine reducing the probability of you getting infected altogether. So it's a reduction in your probability of acquiring a SARS-CoV-2 infection. It could happen though that the vaccine doesn't do that, and so you get infected, but the vaccine can then reduce your probability of developing COVID-19 symptoms after infection. And this is called VSIMP. And this is a conditional probability on being infected. Or it could also happen that the vaccine can reduce your infectiousness. And so that vaccinated individuals are less infectious than others. And we call that VI. And so the thing is that none of these three things that I need for my model were actually measured in the clinical trials. What was measured was this vaccine effect that I call VE disease. And that's the unconditional probability of developing disease given that you're vaccinated. And so, well, obviously, without the given that you're vaccinated, this is an effect on unconditional disease. And I am putting here the formulas of how this relates to these other two. And this will be important for this project, but more so for the next one. And so, oops. Okay, and so we assume that the vaccine is leaky, meaning that all vaccinated individuals see their susceptibility to infection or to symptoms reduced, as opposed to an all or none vaccine. But for this particular project and for this talk, we assume that the only effect of vaccination was a reduction in your susceptibility to infection. And we did a separate analysis where we also assume a vaccine reduction in COVID-19 disease, but I'm not gonna talk about that today. And so for the rest of the first part of this talk, every time that you see VE, what I'm really talking about is vaccine effectiveness in reduction to susceptibility to infection. And then for any given run or scenario, I'm going to assume that a fraction of the vaccine will be wasted because it will be given to people that were already infected and are now recovered. And we also assume that naturally and vaccine-induced immunity lasts 1 year. And so I'm going to tell you a little bit more about how we model vaccination. So remember, I told you I had 16 age groups, but that's not really how the government and vaccination takes place. Vaccination takes place in these big age groups. And so we collided those 16 age groups into 5 big vaccination groups. So children, adults, 20 to 50, 50 to 65, 65 to 75, or 75 and older. And again, because this was back in May of 2020, we didn't know how efficacious this vaccine was going to be. And so we varied vaccine ranging from V, varying from 10 to 100% efficacious. And because I told you I wanted this to be able to be very general, we varied vaccination coverage, so to have enough vaccine to cover 10 to 100% of the total population. And so in this first work, we assumed that you were only given one shot of vaccine and that was enough. And so then we had to decide what is the thing that we cared about? So what were the objective functions that we needed to minimize? And so we chose 4 different metrics of disease burden, and these represent 4 different things that public health officials might be interested in doing. And so the first thing was to minimize symptomatic infections, and this is a proxy for transmission. The second and obvious thing is minimizing deaths. And then we also wanted to do something about healthcare burden. And so we came up with these 2 metrics. So the maximum number of non-ICU and ICU hospitalizations. And so the idea is that if you manage to have the maximum number of hospitalizations below a certain level, then everything else during the epidemic will be below that level. And so for these last 2 metrics, we use the Washington State goals at the time of having less than 10% of occupancy of general hospital beds with COVID-19 patients, and the number of total licensed ICU beds in Washington State as our thresholds, if you will. Okay, and so I want to talk a little bit about how we did the optimization. And I'm sorry for the EP people in the audience, this might be a little bit too technical, but I was told to have a little bit of both. So in terms of optimization, there has been very little work in optimization in the context of public health. And so there has been some theoretical work, I cited 2 papers there, and then there has been some applied to particular diseases, mostly to influenza and a little bit to cholera. But in general, optimization algorithms are not very well suited for these black box objective functions as we have here. And they have never been applied. Well, they have been applied, but they haven't been tailored particularly to public health. And so this is what we did. This was work with my colleague Julie Eaton at University of Washington. So we came up with this routine where we did the optimization in 2 steps. The first step is a grid search. And so the idea is, think about, I have a total amount of vaccine and I want to divide it into my vaccination groups. And so for just to have an example, I put here what it would look like if you would have only 3 age groups. And so the total amount of vaccine, you can think about now about all the vectors that sum up to 1 in this space. So it will look like in 3D, it looks like this kind of hyperplane. And then you can put a grid on top of that. And here in this example, the grid measures is at 25% increments, meaning that, you know, the points here are each have 25% difference in the vaccine. So for example, this point here means that you will use all your vaccine in your last age group. While this point here says that you will vaccinate, you will use 50% of your vaccine in the first age group, 50% of your vaccine in your last age group, and nothing in the second group. And so you have a grid like that layered on top of your unit simplex. Now I don't have 3 age groups. I have 5, and I wanted something that was dividing the whole unit simplex in increments of 5%. And so I put an example here. So if one example in this grid will look like 0.05, 0.5, 0.1, 0.02, 0.15. And what these translates to is use 5% of your vaccine in children, 50% of your vaccine in adults age 20 to 50, then in those age 50 to 65, etc. And so the good thing about this is that you can construct a grid like this at 5% increments, and you can explore all the possibilities of that grid. And so for five age groups, there are 10,000 roughly possibilities. And so what we did is, because these evaluations are fast, is that we actually evaluated our objective function in each point of this grid. And so if we wanted to minimize deaths, we ran them all for each of these 10,000 points. And then we select the best N of those, which N was 50 or 25, I believe. And then just because we don't want to get trapped in local minima and we want to make sure that we really explored the space, we selected another endpoints randomly from the unit simplex. And so they don't have to, they are not in this grid necessarily. Okay, so that's the first step. And then in the second step, we're gonna use regular unconstrained optimization algorithm. And in this case, we tried 5 or 6 different ones, and we ended up settling with MICDE because it was the best one. And so what we did is, in addition to those 2 endpoints that I told you before, we're gonna add another one. And this is I'm gonna call this one the pro rata solution. And so what this solution does is it splits your vaccine across age groups proportionally to their size. And so for instance, if I tell you that I have enough vaccine to vaccinate 50% of the population, what that solution does, it will just give 50% of each age group, of each vaccination group. And so, so we take that solution too. And so now we have 2n+1 starting points, and we're gonna run MICDE on each of them. And by doing so, I will obtain 2n+1 nearly optimal solutions. So each starting point is gonna give me a different optimal solution, and I'm gonna declare the optimal, the best of all of these solutions. And so what are the advantages? It's relatively fast compared to other optimization algorithms like genetic algorithms, for instance. But more importantly, it is searching through the whole vaccine space. And that's important because it's very common in this type of algorithms. It's very difficult to search the whole space, and it's very difficult not to get trapped in local minima. And although I cannot guarantee that my solution is the optimal one in mathematical terms, I know that the solutions are optimal up to 5% of the vaccine. And one very important thing is that this grid is calculated in advance and is independent of the amount of available vaccine that I have, which means that this can be reused for anyone else that says, oh, I have 35 million doses of vaccine. They can use this grid and just do it. They don't have to recalculate it every time. Okay, so what are the results? So the first thing, oops, I lost the slide. Well, I hope you can see this, but so this slide has 10 panels, and each of these panels represents a different vaccine efficacy with 10, 20, 30, 40, that is covered 50, that is here big on red, all the way to 100 down there. And what I plotted here in these, on the y-axis are symptomatic infections, and on the x-axis are days. And the first thing that we wanted to answer is how efficacious a vaccine needs to be in order to be able to mitigate the epidemic, so to slow it down. And the answer was 50%. So if we had a vaccine that was at least 50% efficacious, then we could actually start putting a dent on the epidemic as long as we vaccinated a large majority of the population. And I forgot to tell you, these lines here are different vaccination coverage, and I plotted the optimal solutions. And actually, if the vaccine is at least 60% efficacious and you were to vaccinate a high proportion of the population, you start to see no epidemic whatsoever. So you can actually contain the epidemic with a vaccine that is at least 60% efficacious. Of course, this was all pre-variants. So we were thinking that the virus was fairly stable back then. Okay, and then remember, I told you that we wanted to know who should get vaccinated first. And so what I'm gonna show you here is the results when I'm minimizing VIDs. And so these, you have 10 panels again, one running from 10% to 100% of vaccine efficacy. And this is a very busy plot, so I wanna guide you a little bit. So what you're observing here is total vaccine coverage available to you. And in the columns here is the proportion of each age group, 0 to 20, blah, 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 all the way to 75 and older, that you should vaccinate in that particular age group. And so for instance, in that big red square that I put here is if your vaccine was 40% efficacious and I have enough vaccine to cover only 10% of my population, the optimal thing to do, according to our method, is to give it all, to cover all the 75 and older, and whatever you have left to allocate to the 65 to 75. And so while this is very busy, if one takes a step back and just looks at the first row, what you see is that the answer is pretty much the same. And what this is saying is that for low vaccine efficacy, so vaccine efficacy 50 or lower, what this is saying is you always start with vaccinating the older adults, which in our model and in real life are the ones that are at higher risk for death from COVID. And you go down, and as you have more and more vaccine available to you, you start covering the younger age groups, and you go in decreasing order. However, once you have VE that is 60% or more, then we observe this threshold phenomenon that you're seeing here at 50%, here at 40, and so forth. And so what this is telling me is if you have not that much vaccine, so if you have vaccine enough to cover 50% of your population or less, then you do the same thing that I told you before. You start with the older age groups and you move down. However, if you have a lot of vaccine, if you have enough vaccine to cover 60% of the population or more, then you switch and you cover your high transmission groups first. And that's what you're seeing here. And so what can you actually do now for each vaccine efficacy, vaccine coverage pair? And so what I'm showing you here is the percentage of symptomatic infections averted, and here the percentage of deaths averted. And here I switched a little bit the axis. Here you still have the total vaccine coverage available to you. But here you have vaccine efficacy. And what this is telling is that, say, if you had a vaccine that came out from the trials and was 60% efficacious, then you would have to vaccinate around 70% of the population to completely contain the epidemic. So here you averted all symptomatic infections. And similarly, if you had a vaccine, what this is saying is that if you wanted to prevent, say, 50% of the deaths, which is this line here, then you would have to vaccinate roughly 35% of the population if your vaccine was 50% efficacious. And obviously you would have to vaccinate less people if your vaccine is more efficacious. And the other thing that we looked at is that what happens in terms of healthcare burden. And so these lines here represent the Washington state occupancy goals for ICU beds and non-ICU beds. And what you can see is that only vaccines that have the efficacy of 50% or more can maintain the healthcare system within capacity goals. And now I'm gonna go through. So what happens if you change the objective function? So what happens if now you wanna minimize symptomatic infections? And so this is assuming that the vaccine is 60% efficacious. And so if you want to do that, then you can see that the optimal allocation switches, and instead of vaccinating the high risk groups, you want to vaccinate the high transmission groups first. And so here, the high transmission are the young adults. And then as you move to more severe outcomes, this is shifted to vaccinate the high risk populations. And you have this for low coverage. And you have this threshold that I discussed before, both for ICU and beds. And then I wanna very quickly say that, so now we looked at, I told you we didn't know what percentage of the population had been previously infected. And so we run it with 10, 20, 30, and 40%. And what you can see is that if you have a lower percentage of the population recovered, then this threshold phenomenon occurs with much larger proportion of vaccination coverage. And as you move and you have more people recovered, it goes up. And then if you're at 40% pre-existing immunity, then the optimal allocation strategies tend to be more equitable. And that means that it's less important to cover first the high-risk groups. Okay, so in conclusion, we found that the pandemic could be controlled with any vaccine that was at least 50% efficacious and a high percentage of the population was optimally vaccinated. We also found that over half of the deaths could be prevented with only 35% of the population vaccinated, as long as the vaccine was at least 50% efficacious. And we found this threshold for high vaccine efficacy, by which with low vaccine coverage, you want to optimally allocate it to high risk groups. But as more vaccine becomes available, there's a switch to the high transmission groups. And the other thing that I show you is that depending on what you want to do and what your priorities are, the optimal allocations switch. And so that was the end of that project. And we finished that project in the summer and early fall of 2020. But then we immediately started working in the second project because we knew by then that all the vaccines, or the majority of the vaccines, were going to be given in 2 doses. And so even though we know that the countries were starting to vaccinate, there were not enough doses. And that's even true today, because as of September 2021, and that's still true in November 2021, most low and middle income countries have not had any vaccine at all, or very little, enough to cover 1% of their population. And so we know now that most of these vaccines are given in 2 doses, and you need to wait at least 3 weeks between them. And so there's this question of what is better, to vaccinate twice as many people with a single dose, or half of them with the full dosage. And so the second question that we tackled was who should get these COVID-19 vaccines, but now how many doses they should get. And so the age structure is exactly the same as I described to you. And now we have a model that is slightly different. It has we explicitly model vaccination in this model, and we have 1 dose and then a second dose 3 weeks later. And the model is very, very similar, except that here you go to symptomatic and then you go to hospitalizations. It's the same thing as before. We divided the population in 5 vaccination groups. But now, because I'm explicitly modeling vaccination, I need to tell the rate at which I'm vaccinating people. And we chose 2% or 4% of the population per week. And to give you an idea what this is, so we started this back in, I don't know, November 2020. When Biden assumed the presidency in January, his goal of 100 million people in 100 days is exactly 2%. 2% of the population per week. And we did 6 months in the time horizon because we thought that vaccine we were going to have a lot of shortages at the beginning, but very fast the production was going to keep up, and that was not going to be a problem anymore. And so now, because now we had more data, we knew that vaccination coverage would be at most 50% with a single dose. And this corresponds to vaccinating 2% of the population for 6 months. This is what you will come up with. And so keep in mind, 50% with a single dose is equivalent to 25% with 2 doses, right? And so by that time, it was clear that different places were having very different social distancing interventions, and that was resulting in wildly different epidemics. And we knew this was going to be important for the optimization. And so we considered actually 4 different levels of background transmission. And that would result in an R effective of 1.1, 1.3, 1.5, or 2.4. And again, we had to choose disease metrics to minimize. And this time we chose total infections, symptomatic infections, peak non-ICU and ICU hospitalizations and deaths. And so I already show you this slide. And in my previous, in the first project, we assumed that all of the vaccine efficacy that we were observing in the trials was coming from preventing infection. But by now we had more information about what these vaccines were doing. And although this was still not measured, we assume an equal contribution to this, to VE disease, which is what we observed. And so we roughly assume equal contribution of a vaccine protecting against infection and a vaccine protecting against symptoms. And so what we did know by a year ago, to November 2020, is that these vaccines were highly efficacious. They were around 90% efficacious against unconditional COVID-19 disease. What we didn't know was how efficacious was a single dose. And so what we did is we considered 3 scenarios. One with low single dose efficacy that I'm gonna call SDE. And so what this says is that after 1 dose in light blue here, you would get roughly 20% of your overall protection. And here, a moderate SDE, you will get 50% of your overall protection. So half of what you would get with 2 shots. And here we assume that after 1 shot, you will get 80% of your overall protection. So the bulk of your protection will come after 1 shot. And so we compared our optimal strategy as determined by the optimizer with 2 other strategies. This high risk strategy was what we ended up doing in the US, and that's you start with the older age group that's 75 and older, and you vaccinate all of them. And once you're done with them, you go to the 65 to 75 age group and you vaccinate all of them, and you go like that, by decreasing order. And we compare that to that pro rata strategy that I told you before. And that's, you go ahead and you vaccinate everyone in your adult population as soon as you can without keeping track of any order. And so what are the results for that? So first I wanna focus on the low transmission. So that assumes that you have an R effective of 1.1 or 1.3. And so what you're seeing here, and you're gonna see throughout the rest of the talk, is 3 columns that correspond to assuming low single dose efficacy, moderate, or high. And here in each row, you're seeing if you have enough vaccine to cover 10% all the way down to 50% of your population with 1 shot. And here you have the 5 vaccination groups as before. And so, and light blue is 1 dose and and dark blue is 2 doses. And so what this is saying, for instance, is you vaccinate this proportion of people with 1 dose of the 75 and older, and this other proportion with 2 doses. And so now, again, if you look at the big picture here, and I look at the first 2 columns, what this is saying is that the optimal vaccination strategy is gonna fully protect the high risk age groups. So those that are 65 and older first with 2 doses. And then as I have more vaccine available to me, I start to cover the younger age groups. However, if I have a highly efficacious vaccine after 1 dose, then the optimal strategy is this pro rata strategy, where you just go ahead and you don't care about order and you just vaccinate as fast as you can in everybody that that you can. And so how well does this strategy, the optimal strategy, compare to the other ones? And so what you're seeing here is, again, each column corresponding to low, moderate, or high SDE. And on the top row, you're seeing, assuming R effective of 1.1, the bottom row 1.3. And here I graph, 10, 20, 30, 40, or 50% of your population coverage. So vaccinating with one dose, either 10 all the way to 50%. And on the y-axis, you're seeing the proportion of deaths averted. And so what you can see is that for low or moderate SDE, using the optimal will give you, will avert 12% more deaths compared to the high-risk strategy, especially if you have low vaccination coverage, but it will actually avert 45% more deaths compared to the pro-rata strategy. So if you were in a situation where the vaccine has very low efficacy after one dose, doing a pro-rata strategy is a gigantic waste of resources. However, the situation is reversed if you have a vaccine that is highly efficacious after one dose. And so if you're in this scenario, then again, for low coverage, vaccinating with the high-risk strategy would avert 22% less deaths than if you were to vaccinate optimally with the pro-rata strategy. And I want to point out that as in this setting, as you have more and more vaccine available to you, the difference between strategies start to be not as important. But that's for minimizing deaths. Now, if I use what happens in terms of the infections, and so here I plotted the 50% coverage and the optimal strategies. And what I plotted here is the prevalence of infections per 100,000. And so in black is the baseline, and again, blue is optimal, pink is high risk, and green is pro rata. And so what you can see is that even though in the previous slide, I show you that for the high single dose efficacy, the number of deaths averted, if you were to use the high risk or the optimal, were very similar, you can see that in terms of what's happening with transmission is not. And so choosing the optimal really matters because you're kind of like, you're also doing something to transmission. And then what happens if you consider places where they didn't have high social distancing interventions in place? And so in that case, then you can see that the optimal allocation strategy is always to vaccinate the high-risk groups. And you do so with 2 doses if your vaccine is not very efficacious after 1 dose or if it's moderately efficacious. And you do it with a single dose if you're in the high SDE setting until you have enough vaccine to cover your high-risk populations with 2 doses. And at that point, you switch to 2 doses to them, and then you vaccinate with 1 dose the remaining age groups. And what would happen in that case? And so this is the same plot that I showed you before, but now it's for our effective of 1.5 on the top and 2.4 on the bottom. And so it's the same thing. So if you were to use the pro-rata strategy, you would avert 47% less deaths compared to the optimal strategy, which in this case is the high-risk strategy. And so, but if you are in the high, in a situation where your vaccine is highly efficacious after 1 dose, then again, you would avert 12% more and 23% more compared to the pro-rata and the high-risk strategy, respectively. And so I want to do a quick summary. So what happens if you assume that you have enough vaccine to cover 50% of your population with a single dose? And so what happens is that if you have a low or moderate SDE and you have low or moderate transmission, then it is optimal to vaccinate the high-risk groups with 2 doses. But if you have a vaccine that is highly efficacious after 1 dose, then you should go with the pro-rata strategy. However, if you're in a situation where you have a lot of transmission going on, then you shouldn't. You should always protect your high-risk groups first with 2 doses, and then with a single dose, whatever you have left. Okay, and then I think I'm gonna skip this. All of this is to say that, again, different objectives give rise to different optimal allocation strategies, but I'm gonna skip it because I wanna show you the other thing. So I told you at the beginning that we considered a vaccine that even that what we observed in the trial, the VE against disease, was roughly half given by half of vaccine efficacy against susceptibility and half vaccine efficacy against symptomatic disease. But we also run scenarios where we said, well, what if all of the efficacy that we're observing in the trials comes just for preventing symptomatic infection and not from preventing infection? And that's this row here. And so what we saw is that if a vaccine had this profile here, then the optimal thing to do is always to directly protect the high risk groups. And this makes sense because in this case, the vaccine is not doing anything against transmission and against infection. And I need to point out that these three things, they all give rise to a vaccine efficacy against disease of 90%. So even though what you observed in the trial is the same, you could have this distribution of how the vaccine is acting in very different ways. And so here, the optimal thing to do is to protect the high-risk groups. Well, if you have a vaccine that has some contribution protecting against infection, then you favor strategies that will cut down transmission. And so in conclusion, if a single dose is highly efficacious, then single dose campaigns are optimal and can avert up to 22% more deaths than high-risk strategies. But if a single dose has low or moderate efficacy, then these pro-rata campaigns are a huge waste of resources. And optimally allocating your vaccine can avert up to 45% more deaths than these single dose strategies. And so back in December when I finished this, and even now, I still believe that it's absolutely crucial to know how efficacious these single dose these single dose vaccines are, because it might be very tempting, especially for low and middle income countries, to stretch their vaccine supply by vaccinating more people with a single dose. And so really knowing in which of these scenarios you are would be very, very important for those countries. And with that, I want to acknowledge Peter Gilbert, who funded this work, and COVID-19, the COVID-PN, NIH, and Fred Hutch, who also funded this work. And I will be happy to take any questions.
Thank you, Dr. Matrajt. And this was really fascinating and interesting seminar and the results. There are a couple of questions to get us started. Maybe in the interest of time, I can ask a few or just read them. And then if others have questions, please go ahead and add them to the Q&A or to the chat. There was one question from Jonathan, who's a doctoral student here in epidemiology, that I think is a great question for regarding some of the, I guess, technical aspects of the optimization. And he asking for those four objective functions, is it possible to combine them together as a whole function or in some way? Since I think all of those are important outcomes and they need to be addressed. So any comments about that?
Yeah. So there's a big field in optimization that is called Pareto optimization that does exactly that. So when you have these competing interests, because it's kind of competing, like transmission is competing against death. And so you can certainly do that. You can, and I mean, the easiest thing to do is you can just come up with a function where you weight those things and you say like, you know, like I believe that deaths are more important than transmission by this much, and you optimize by that. I mean, that's the easiest thing to do. Or you can go with Pareto optimization. There's an interesting paper about Pareto optimization that just came out or is about to come out in PLOS Compile and for COVID. It has a lot of simplifying assumptions, but it's the first paper that tackles that. Yeah, that's interesting. Thank you.
Thank you. And we had a follow-up question in terms of what constraints did you put into the optimization? So I guess, yeah, limited vaccine dose, limited funding, others that you consider?
Yeah, so I didn't talk about this, but you obviously need to constrain on the number of vaccines that you give to each vaccination group, because you cannot vaccinate more people than people in that group. That's it. Those are the only constraints. So you're constrained by the amount of vaccine and by that. And other than that, we found that unconstrained methods work better than constrained methods.
That's interesting. That's what you said, that Nelder myth was better.
Yeah, so we have started working on a similar problem for cholera months before the pandemic started, and we had tried a bunch of optimization algorithms, and we stochastic algorithms and deterministic and unconstrained and constrained, and at the end of the day, Nelder myth was incredibly, because it's the oldest, it was also the best.
There's this another question from Dr. Jahan Jan asking if you would consider modeling, or if you've modeled the impact of booster shots, or is that something you're already looking at? And
yeah,
any insights you might have? Yeah, from
my colleagues at the Hutch are already working on boosters. I haven't started. I suspect that boosters are not gonna do much because you have to give them to a very large proportion of the population to cut down transmission. So I mean, the boosters and the boosters were accepted for the time being only for, I mean, basically for the oldest age groups, and those are the age groups that move the least. And so you're not gonna cut down transmission by vaccinating 65 and older. But that's my intuition, but I haven't worked on that yet. I mean, we will all need a booster eventually. That's a fact, and that's okay. That's normal. That's how most of vaccines work. You have to have boosters, but yeah.
So what you're saying is that probably, or the implication is that probably some of this work already applies to the booster under, I guess, a scenario where basically but immunity has waned, and maybe the variants have changed enough that you can think of it as just starting again. Is that
yeah? I mean, you can think about boosters as, so now I have a high proportion of my population immune, and the vaccine efficacy that I show you against infection, which we thought it was pretty high during the first phase of the pandemic, now we think is much lower, depending who you read, is 40 to 70% as opposed to 80%. If and so you can look at that and say like, oh yeah, I need to vaccinate a lot of people to cut transmission. I mean, it doesn't really apply because now you have a much larger proportion of the population with some level of immunity. But what I mean is that in terms of transmission, obviously in individual terms, the boosters are very important. Like, you want your parents to get the booster, and you want to get the booster yourself when it comes out. But at the population level, I personally don't think, but I might be wrong, of course, but I don't think it's gonna make a difference unless you vaccinate a very high proportion of the population.
Thank you. Next question. So from Dr. Andrew Brower, was your goal to connect with policymakers directly, or just put this work into the literature? Did you feel policymakers were receptive or use your work? Any tips for translating work like this to non-academic policymakers and decision makers?
Yeah, so I didn't put this slide, but this work was very well received, both by policymakers and by the media. And in terms of policymakers, I know WHO used this work in their roadmap priorities, in their prioritization roadmap. So it was definitely used by policymakers, if not here in WHO. And I think, yeah, so it has been used, and so what was the second part of the question? Was how
any suggestions
to translate
of how to make it? Yeah,
it's hard. I think during the pandemic it has been hard because, well, it hasn't, because I think that policymakers are starting to see the value of quantifying their decisions as opposed to making them ad hoc. And so in that sense, I think that mathematical modeling as a whole field has received a gigantic boost. Like now policymakers are aware that this exists and that this is useful for them, and that they can do things with this and take decisions in a much better informed way. And now I think that the difficult part has been the oversell. Like you see all this, the media saying, well, the model predicted these many million deaths and we didn't observe that. And it's like, well, yeah, but that's because you did something about it. And I think that's very difficult for the public sometimes to understand. And it's also very difficult to understand what are the limitations. And I think that in a way we haven't been very good about explaining the limitations of modeling. It's not a crystal ball, but I think it's been interesting, definitely, and at least from my perspective, it has been interesting to engage with public health officials. Like I have engaged with the Department of Washington, to the Department of Health in Washington State and in Oregon State, and it's been interesting.
Thank you. Related to, and well, just for everyone, we're going to go to the end of the hours. I know some of our students need to go to their classes. So feel free to log out, we'll record, but we'll continue with a couple more questions and get to 1 p.m. here. So related to the previous question, there's an anonymous question. Do you think the early days of vaccine allocation in the US was driven more by science, like you've presented here, or by politics? How do you think that's affected vaccine uptake to this day? Hard question.
I think it was guided by science, definitely. But I personally think that we should have done clinical trials measuring one dose. And I think it was a waste opportunity not to do so. But it was definitely guided by science. I mean, the science, the US took the safest bet, meaning, given the information we had, like compared to the UK, for instance, like the UK extended the interdose period to 8 weeks or 12 weeks. And I mean, compared to them, they took a chance, because if the vaccine had not been very effective after one dose, then they could have had huge problems, but they didn't, because the vaccine was very effective after one dose. And I argue that we shouldn't have had to take any bets. I mean, like, we had already done so many trials, and it would have been so much better to have, a third arm with a one dose with 8, or with a delay of 8 weeks or 12 weeks or whatever, and just know the answer. Because if we had done that, we would have been able to come back and to open up the economy much faster, in my opinion. So in that sense, I think it was a waste opportunity, and I hope that that's kind of like a lesson learned from this pandemic. But it was definitely guided by science, in the terms of, given the information we knew, we did what we knew was best.
So limited science. That's a very good point. One question from another anonymous attendee. So as I understood, these studies have been on a national level, but do you think the same conclusions can be applied globally, meaning to characterize countries as high transmission countries and low, as well as high risk countries and low, and spread the vaccine accordingly?
Well, that's why I did it so general. And that's why I did, what if you have 10% of vaccine, and what if your vaccine efficacy is 60%? Because Pfizer vaccine is very high, but like in Chile, they used Sinopharm, and the efficacy is much lower. And so I wanted something that will provide general answers. And so in that sense, it's not very specific, but I think that there's now, like, I don't know, 100 more papers with that, with some version of these, and they all kind of come to the same conclusion. Like even if you do a very specific, a highly specific model for Chicago, I think that you're gonna find that the optimal way of putting vaccine is the same, meaning it depends on what's the level of transmission in that particular city, and it depends on how much vaccine you have, and obviously which vaccine you're using. So in a sense, I hope I provided a general answer with this work. Oh, and obviously, by doing something general, you also lose, right? I mean, there's some things you win and there's some things you lose. I mean, you lose in the kind of like in the details, and you gain in being able to apply it to many places, which is, I think, why the WHO kind of liked it, because they could see a very wide variety of things, all in once.
So I guess that's a suggestion for the modelers in the room that yeah, I guess doing a wide range of scenarios that cover a lot of potential settings is helpful. There's one final question that I do want to give you a chance to answer, which is from Marina Valle. Thank you. Such interesting work. In your opinion, what percentage of the 5 to 11-year-old population will need to be vaccinated to have an impact on reducing transmission? Any thoughts?
So we have a paper about that. I am not the lead author. I did very little on that. But you have to vaccinate a very high proportion of the 5 to 11s. And that model is kind of the opposite to this. That is highly calibrated. It has been calibrated to King County, which is the county where Seattle is on. And we found that you have to vaccinate over 80%, I think, to do something to cut down on transmission. And that's just because Delta is so incredibly transmissible.
Yeah. Well, on that note, well, it's good to know, right? To set the right expectation. So I want to thank foremost, of course, and Dr. Matrajt for her wonderful presentation and joining us today for the Epi Department seminar and MICDE seminars, joint seminars. I want to also thank MICDE for co-sponsoring this seminar with the department. And I want to thank all our participants and thank you for all your questions. I think we had a great discussion, and I think as you can see, there's a lot of interest in this type of work that is at the interface, of course, of epidemiology, computational science, and public health. So thank you, Dr. Matrajt, and we'll close the seminar.